Assalamualaikum dan selamat salam satu Malaysia. Thank you very much, Mr. Chairman, for the kind introductions. I'm coming from Kuantan, from University Islam Antarabangsa, or what we call IUM. It's located in East Coast. There are two campuses. The medical campus is in Kuantan. We are using Hospital Kuantan as Hospital Tengku Afwan Azan as our teaching hospital. I was formerly from there last time. Alright, the task that is given to me is to talk on the management of local regional recurrence cancer of cervix. As you know, approximately 30% of patients with cervical cancer fail after primary treatment. Management of recurrent cervical cancer is clinically difficult. Prognosis of this recurrent disease is usually grim unless, except for those lesions or those recurrence, is central and small. Overall survival rates in the recurrent disease is reported between 3.2% and 13%, so it is rather low. Recurrent disease after primary treatment of cervical cancer could either be in the pelvis, distance, or both. And after primary surgical or radiotherapy treatment with no lymph nodes and parametrium or surgical margin involvement, there will be around 10 to 20% of patients will inevitably recur. When there are lymph nodes involved in the primary treatment, 70% will relapse. In a systemic review from 70 trials, after the primary treatment, the median time to recurrence ranged from 7 to 36 months. Rates of recurrence range from 8 to 26%. Of these, 14 to 57 patients recur in the pelvis. And at the same time, it is reported that between 15 and 61 of patients recurring in distance or multiple sites. Upon recurrence, the median survival rate is low. It will take between 7 and 17 months. The management of local recurrence of cervical cancer required a multidisciplinary team. It requires a coordinated effort of various professionals in the team, and importantly as well, patients' understanding and agreement with the proposed treatment. As we know that our patients are usually complete with a recurrent disease, we may not, able to treat them as much as we can. So we have to respect their wishes about the outcome of our decision they make. The professional people usually in the team are the gynecology oncologists, radiation and medical oncologists, palliative care physician, nursing, and even sometimes psychologists, as well as other support staff. For the local regional recurrence following primary radiation therapy, the site of pelvic recurrence, this is historical data, was way back in 1949, but often quoted by many in the literature review. The following radiotherapy, 27% of recurrence occur in the pelvis, uterus, and upper part of the vagina, and 6% in lower two-thirds of the vagina, and 43%, a majority involving the parametrium, including the pelvic wall. The rest are distant metastases, particularly pulmonary. Following radiotherapy treatment, the incidence of locally recurrent disease after radical radiotherapy increases with increasing stage of the primary disease. Perez et al. Reported a total pelvic failure after radiotherapy alone is 10% in stage 1B, but steadily rise to 74% in stage 4. Approximately 25% of pelvic recurrence were central and 75% involving the parametrium. In local regional recurrence following hysterectomy, for the hysterectomy and pelvic lymphadenectomy for the stage 1 disease, Larsen et al. Reported that overall incidence of recurrence is around 11%. Majority, 63% of them, recur in the pelvis or in the vulva, and 37% of them recurs outside the pelvis. It is interesting to note that majority of these patients of the recurrence occur within a year after primary treatment. Recurrent patterns after radical hysterectomy and pelvic lymphadenectomy for cervical cancer in stage 1 and 2A disease, as reported by our counterpart in Thailand, have shown a similar pattern of distribution. The incidence of recurrence in their 218 patients was around 9.1%. The recent publication of recurrence following radical hysterectomy was published by Pura B et al. That showed that the recurrence rate of the disease is 25%, and 50% patients had local regional recurrence, 27.5% local regional plus distant metastasis, and 12.5% distant recurrence. The following radical hysterectomy, only 25% of patients recurrence at the upper part of the vagina. What is the lesson here to learn? That majority of patients after radical hysterectomy present the recurrence in the pelvis. In general, only a few patients will have a central pelvic recurrence. That is important to note that this group of patients has a better prognosis compared to the others. The common sites of recurrence is in the pelvis wall, followed by the distant metastasis involving the pelvic nodes, bony metastasis, vertebra bodies as well. Diagnosis of local recurrent disease. It is interesting to note that 46 to 95% of recurrence are actually diagnosed by symptoms only. The symptoms, common symptoms are leg pain, abdominal pain, pelvic pains, leg pains, lymphedema, vaginal bleeding or discharge, urinary symptoms, cough, and weight loss. Physical examination alone, by means of bimanual examination, specular examination, rectal vaginal examination, is capable of detecting between 29 to 75% in asymptomatic patients. So it is important to note this. It is better than imaging or vaginal cytology, where vaginal wall cytology, though it is high specificity but poor in high in specificity but poor in sensitivity. The treatment of local regional recurrence decision should be based on, one is a prior treatment, what the patient had, and the extent of the disease and the performance of the patient. The treatment option for the local regional recurrence following radiotherapy, the options are radiation therapy, concurrent chemotherapy, and pelvic accentuation. These are laboratory evidence, i.e. from well-controlled studies. For the radiation therapy, it is given as a radical external beam or intracavitary brachytherapy. The wall recurrence has shown a better result compared with the nodal recurrence. When there is pelvic wall involvement, the prognosis is poor. Overall 5 years survival, 5 years disease-specific survival was quoted around 40%. In a report from Grisby and the group following pelvic radiation and brachytherapy, their result has achieved 74% overall 5 year survival rate. It is noted that distant metastases were the most common site of pain. So, in this group of patients, systemic chemotherapy should be considered as adjunctive treatment for this patient. Concurrent chemotherapy following radical surgery. Cisplatin is the most active drug, as we know. Other agents, fluorouracil, doxorubicin, epirubicin, ifosfamide, paclitaxel, gemcitabine, also active in cervical cancer. They can be given as single or in combination. The combination treatment consists of 3 cycles of concurrent cisplatin and 5 fluorouracil. Has shown a good response, which is 35%, 10 years overall survival rate, with acute toxicity rate of 27%. It should be noted here that in a combination therapy, there is increased response rate and prolonged time to progression, but at the cost of toxicity and no prolongation of overall survival. Pelvic accentuation after radical surgery may be an alternative, particularly in patients presenting with fistula, to radical radiotherapy and concurrent chemotherapy in selected patients without pelvic wall involvement. Treatment option for the local regional recurrence following radiotherapy. Radical hysterectomy, type 2 or type 3, may be applied for the recurrent disease that is confined to the cervix, small lesion less than 2 cm, and originally stage 1B or 2. He has shown that 10 years survival of 80% could be achieved if the tumor is less than 2 cm. Radical hysterectomy is associated with a high complication rate, short-term or long-term. DVT, bowels, bladder complication, cellulitis, leg edema, fistulization, among others, are the common complications. It has been reported that a permanent complication can be as high as 40%. In selected cases, pelvic accentuation may be the choice when the lesion is small and central, no pelvic wall recurrence, no pelvic wall involvement, and no extra pelvic metastasis. The role of chemotherapy in local vaginal recurrence is almost similar with the role of systemic chemotherapy in metastatic cervical cancer. Cisplatin, as I mentioned earlier, is found to be the single most active agent to treat the cervical cancer. The response rate with a high dose of cisplatin, that is 100 mg and compared to 50 mg, is not associated with any improvement in progression-free disease or overall survival. And cisplatin-based combination therapy is associated with high response, longer progression-free survival than single-agent cisplatin, but there is no difference in overall survival. Response rates to chemotherapy are consequently higher in patients with good performance status and extracellular disease, but low in previously eradicated sites. The impact of chemotherapy as a palliative and survival remain unclear. That is the picture from Contact, very beautiful islands and beach and sea. Alright, pelvic exenteration. The threat of unilateral leg edema, sciatic pain, and urethral obstruction almost always indicate unacceptable disease involving the pelvic side wall, and therefore palliative measures are indicated in this group of patients. Imaging, chest X-ray, CT scan, MRI to exclude and extend the distance if necessities are required before embarking pelvic exenteration. Despite a thorough pre-operative procedure before pelvic exenteration, between 30 to 60% of cases are found to be unsuitable for exenterative surgery at the time of lectotomy. So, therefore, it is important to evaluate thoroughly prior to surgery to exclude extrapelvic tumor. During the operation, exploration of the peritoneum should be meticulous to ensure the tumor is susceptible. Biopsy of the lymph nodes or any suspicious lesion should be taken and sent for further section. Pelvic exenteration is associated with severe post-operative complications, intraoperative complications. The peri-operative mortalities were high as 10 to 20% in previously reported. But with improvement of surgical technique, particularly in diversion procedure of the urine, the using of continent urinary pouch, and staples for the bowels, as well as intensive post-operative care, have led to reduce the peri-operative morbidity and mortality following pelvic exenteration. The current mortality risk of pelvic exenteration nowadays should be less than 10%. Pelvic exenteration is the therapy for the central pelvic tumor recurrence. It is extensive operative procedures. Therefore, exenteration is not to be performed for palliation. There are 3 types of operations may be used: anterior exenteration, posterior exenteration, and total exenteration. I do not intend to go into detail on this. Patients who have isolated central recurrence without pelvic fixation or regional metastasis can be cured in as many as 60% to 70% by pelvic exenteration. The role of palliative in local regional recurrence involve re-irradiation therapy, palliative irradiation, and chemotherapy. Pelvic re-irradiation is generally not possible in previously irradiated patients because there is a high potential damage to the bladder and the rectum. Patient palliative pelvic irradiation can be employed for the symptomatic relief. The chemotherapy response varies from 17 to 50%. The palliative chemotherapy impact on survival remain unclear. Other modalities of treatment for the local regional recurrence, that is LEER, laterally extended endopelvic resection, is a novel, innovative and new approach of treating the disease, the recurrent disease, which previously not amenable for treatment, now can be done with this technique. LEER is performed as a combination of at least two of the following procedures: total mesometric excision, and total vesical excision. In cases of lateral pelvic tumor fixation, the inclusion of the pelvic wall and floor muscles in the resection is done to ensure the completeness of LEER. Hockel reported in his series of 100 patients at a median follow-up period of 30 months, the probability of 5 years recurrent-free disease are 62%, and disease-specific overall survival is 55%. Just bear with me in a minute. It's the last 2 slides. All right. Okay, we are here just now, right? All right. Another modalities of treatment is a combined operative radiotherapeutic treatment, CORT. It is feasible option for curative intent in selected patients who present with pelvic floor recurrence. It's a complicated surgery which involves total resection of the tumor at microscopic margin. It involves transposition of the pelvic of the abdominal wall and thigh muscles into the pelvis for modulation of high-dose radiotherapy to the pelvis. The 5-year survival probability calculated with this method was 44%. The overall local control rate was reported between 68 and 85% in the Hockel series. Another approach for the local regional recurrence is intraoperative radiotherapy treatment, IORT. Intraoperative radiotherapy is an intensive radiation treatment that delivers a concentrated beam of radiation to the tumor as they are located during surgery. IORT allows direct radiation to the tumor while sparing normal surrounding tissue. The 5-year disease-specific survival and local control rates were 43% and 48% respectively has been reported. Finally, this is my last slide. As to conclude my presentation, I summarize what I have said in this algorithm. When you have a cervical recurrence, you must first to make sure that you have excluded extra-pelvic recurrence before you embark in the specific treatment that I have said earlier. With this, thank you very much for your attention.
Thank you, Pak Mongkap, for your lecture. There's a slight change in the